welcome to our webinar, Accessing Healthcare in Epilepsy That's Right for You. My name is Debbie Leone, and I'm going to just share my screen here real quick. Okay, I am the Information Services Manager for the Epilepsy Foundation of Minnesota. I want to welcome you here. We're excited to be hosting our second webinar of Epilepsy Awareness Month. Before we get started, I do want to run through a few housekeeping items. First of all, this webinar will last 1 hour and 15 minutes. For the best webinar experience, we do recommend that you close out any extra windows that you might have open on your computer or other device, especially any kind of video or audio streaming apps that might use up a lot of extra bandwidth. We will be providing certificates of attendance. They will be sent out in an email within 3 business days after this webinar. And we are recording tonight's webinar, so a link will be posted within a couple of weeks for future viewing. Just a small disclaimer, while the Epilepsy Foundation of Minnesota is hosting this webinar, all content and discussion points are led and delivered by our guest presenter, Dr. Catherine Nichols of Mayo Clinic, who I will be introducing shortly. This information tonight is being shared with you to inform you of the aspects of healthcare in epilepsy. However, all potential treatment options should be discussed with your own medical provider. Our presenter will be answering questions from attendees at the end of tonight's webinar. However, we do encourage you to submit your questions as they occur to you throughout the evening. To do that, you can click on the Q&A icon at the center bottom of your screen, and then type your question into the box that pops up and hit send. We will read and answer those questions during the Q&A session at the end of the presentation, as I said. Please note that to avoid confusion, we have disabled the chat feature. In addition to myself and Dr. Nichols, EFMN's Executive Assistant, Mary Mavison, is here in the background, and she will be handling technical aspects of the webinar. So if you do run into any technical issues or problems, please just type those questions into the Q&A as well. Mary will be watching that throughout the webinar, and she'll do her best to help you out if you're having problems. I also want to mention that we do currently have our closed captioning turned on. So if you prefer not to see the subtitles, you can click on the live transcript button that's at the bottom of your screen, and then click on hide subtitle. If you don't see that live transcript, it has a little CC in what looks like a little TV screen. If you don't see that, you can click, there should be 3 dots at the bottom right, and you can click on them and then click hide subtitle. Our objectives for tonight's webinar are to identify the various types of healthcare providers and what each one has to offer, to know when to seek out an epilepsy specialist or comprehensive epilepsy center, and to recognize the potential barriers to accessing care and ways to overcome them. So I would like at this time to introduce our presenter. Dr. Catherine Nichols is certified in neurology with special qualifications in child neurology, clinical neurophysiology, and epilepsy. She's an associate professor of neurology at Mayo Clinic and is also the EEG course director for the clinical neurophysiology courses, the child and adolescent neurology recruitment chair, and has recently assumed the role of EEG lab director. She collaborates with pediatric epilepsy specialists throughout the country as a leader of the Pediatric Epilepsy Research Consortium, or PERC, to determine best practices and treatments for early onset pediatric epilepsies. She's also an active volunteer, we're happy to say, for the Epilepsy Foundation of Minnesota, serving on the Professional Advisory Board, the Regional Advisory Council, as well as epilepsy.com. So welcome, Dr. Nichols.
Thank you so much for giving me the opportunity to present this evening and participate in this webinar. As Debbie said, tonight we're going to be reviewing the healthcare and epilepsy treatment that's right for you. Next slide. And we already reviewed these objectives, so I think we can dive right into the talk. I have no financial disclosures. I will discuss some non-FDA approved therapies, as is very common for any talk in epilepsy, because we often need to think outside the FDA box. Next slide. So let's start off with the goals of epilepsy treatment. And this is the goal of every epilepsy clinic. We want our patients to be seizure-free. We want them to not have any medication side effects, and we want their epilepsy to have no effect on quality of life. Those are the three main goals. Next slide. So let's talk about what to expect from epilepsy care. And we're going to review epilepsy care at the various levels where people can receive care. And there are specific criteria that denotes the different levels of care and different organizations that you can visit for your epilepsy care. Next slide. So we're going to start with level 1. This would be the emergency department or your primary care clinic. Next slide. So who can be treated here? You're going to go to the emergency department if there's an acute event concerning for seizures in someone who may or may not have epilepsy, or in people who have known epilepsy if there's an acute exacerbation. So seizures are suddenly becoming longer, stronger, more frequent without any known cause. If someone is having a prolonged seizure or status epilepticus, which is a medical emergency, then they would come to the emergency department either via ambulance or a personal vehicle. Next. So what can we expect from the emergency department? If someone does not have a diagnosis of epilepsy, or they have a new spell type that is different from their usual seizures, we would expect the on-call emergency department physician to take a careful history of the events, any sort of trigger that may have led up to it, exactly what happened during it, how they felt afterwards. You would receive a general medical exam, and from that, they may decide to do additional evaluation there right in the emergency department, including some sort of brain imaging. They might check out heart rhythms with an electrocardiogram. If possible, they may try to get an EEG in the emergency department, although that can be pretty challenging, or they might do some labs or any other evaluation that they see fit. Next. They might prescribe a rescue medication if this is someone who does not have known epilepsy and there's enough concern that the event represented a seizure. It's pretty uncommon for an anti-seizure medication to be started right in the emergency department. If there is significant concern that events might be ongoing or the event might be due to underlying illness, infection, trauma, then they might be admitted to the hospital. Most often, you would just be referred to level 2 care. Next. What about people who have known epilepsy and they're just having an acute exacerbation? So again, seizures are suddenly worse for no clear cause. It's, again, going to be pretty similar. You have a history, an exam, but this time we're not trying to sort out what the events are. We're trying to sort out why seizures are being worse. But again, the evaluation is pretty similar with imaging, labs, might check out heart, might do an EEG. Next. If someone with epilepsy comes to the emergency department, expect this to be acute management of seizures. So again, looking for an underlying cause, we're trying to kind of put out this initial fire. So it may require admission to the hospital, it may not, but do not expect this to be a second opinion for epilepsy care. That emergency department team is unlikely to make a lot of changes to your epilepsy management. They're not going to prescribe a new medication. Again, view this just as kind of acute symptomatic care where we're trying to put out that fire. They're trying to make it safe for you to go back home and then be evaluated in an outpatient setting by your neurologist. So who can be treated at this level? Certainly, initial visits for indeterminate spells can be treated by their primary care physician, your primary care provider. Again, if it's not viewed to be an emergency, if it was a single unprovoked event, completely back to baseline, you might be able to see your primary care provider. And your primary care provider will do the same history exam. Kids with uncomplicated febrile seizures only can be followed by their primary care provider. Or rarely, I have some adults who I've cared for many years. They've been seizure-free for a decade. They're on a stable medication regimen. And rather than graduating from my pediatric clinic, they speak with their primary care provider who is comfortable renewing the prescriptions. That's pretty uncommon. Like, I can think of a handful of times in the last decade when that has happened. Next. So what can you expect? Again, the indeterminate spell or febrile seizure, it's going to be pretty similar to the emergency department. For that continuing epilepsy care, again, this is a pretty rare circumstance. You need to have someone who is seizure-free on stable medications for years. It might be someone who lives very remote from a specialist, so it's just really challenging for them to get in with a specialist, but typically it's going to be done in conjunction with a specialist. So there is a neurologist that primary care provider can contact if there are any questions or concerns. You need to have a primary care provider who's comfortable doing this. As a physician, we never want to put each other in a situation where we feel like we can't provide the proper care. And in essence, this would be used just if someone requires prescription refills and standard forms like driving forms, and that's it. Next. So moving on to level 2 epilepsy care. This is your standard neurology clinic, either adult or pediatrics. This is where most people can safely receive their epilepsy care. Now, someone might be seeing a level 2 neurologist within a specialized epilepsy center. For example, I work at a quaternary referral center as a child neurologist. But within the division of child neurology, not all of us have epilepsy subspecialty training. So if you're seeing one of my child neurology colleagues who has not done the additional epilepsy training, that's viewed as level 2 care. So who can be treated here? Honestly, most patients. So patients being evaluated for indeterminate spells. So, are they seizures? Are they not? Someone with newly diagnosed epilepsy, even if they are not yet seizure-free, if they're on their first medication, possibly even on their second medication, they could be followed by a level 2 neurologist. Someone who is well controlled on medications would definitely be followed by a level 2 neurologist, or someone who has stable epilepsy. What does that mean? It means someone who likely has seen a subspecialist and it's been determined that because of underlying causes, they probably will not be seizure-free, but their epilepsy is stable. So they can be followed in level 2, and often people who have been seen by an epilepsy subspecialist will be seen on a consultation basis, and then they will take those recommendations back to their level 2 neurologist. Epilepsy subspecialists usually provide care on a consultation basis only. Next. So what are we going to expect from the indeterminate spells patient or someone with new onset epilepsy? Again, we always start with the basics, history and exam. But the history and exam are going to be longer than what they might do in an emergency department. We're going to look for certain seizure risk factors. We're going to try to, again, determine if the event represented a seizure, and then we'll take it that next step. If it was a seizure, what type of seizure was it? The exam will be both a general exam, but then we'll also do something that we lovingly refer to as the neuro exam or the neurology exam, which is a little bit different than your standard exam. We're looking for coordination, we're looking at strength, we're looking at abilities to think and speak, so a little bit different than your general exam. Often we'll do an EEG. That could be a routine outpatient EEG, so something that's usually around an hour, or may require an overnight or prolonged EEG. If we're concerned enough about the event, then it might represent seizure. Often we'll do some sort of imaging of the brain, most commonly with MRI. Again, if we have a high enough suspicion that it represented seizures, we'll often prescribe an anti-seizure medication, and often a rescue medication as well. So let's pause here. What are anti-seizure medications and rescue medications? Anti-seizure medications used to be called AEDs, or anti-epileptic drugs, but that's really not an appropriate name because we're using medications to treat a chronic disease. So if you have high blood pressure and you take medication for that, it lowers your blood pressure, but you don't say that you don't have high blood pressure anymore. You say you take medication for high blood pressure, and either it works or it doesn't work. If you stop taking the blood pressure medication, your blood pressure goes right back up. Same thing with anti-seizure medications. They don't take away the epilepsy. So if you take medications for 2 weeks and don't have seizures and stop taking the medications, the seizures will likely come back. On the other hand, a rescue medication is used if a seizure is going on longer than what would be expected, and there is concern that it's not going to stop on its own. Not everybody requires a rescue medication, but because they're so accessible these days, a lot of people are prescribed one. And then you'll also discuss a plan for any sort of additional testing if needed. Next. What about return visits for epilepsy? At most epilepsy return visits, you will discuss, any sort of labs or imaging that happened before then. You may or may not have these. Most importantly, you'll talk about seizure control, and you'll talk about side effects from the treatments, usually medication side effects. We'll want to know if any doses of medications have been missed, and if you know what to do if you miss a dose of medication. That's also important to discuss. You'll discuss any plans for changing medications or staying the same, if you need a new one, if you need dose adjustments. Next slide. You will review any additional testing if needed. And again, you don't always need additional testing. If you're not seizure-free, you can talk about additional treatment options, or if there are intolerable side effects to the current treatments. You'll want to discuss epilepsy comorbidities. Remember, epilepsy doesn't happen in a vacuum. Epilepsy or seizures are a symptom of underlying brain dysfunction. So if the wiring of the brain is not working properly, yes, epilepsy and seizures are one of the symptoms, but you have other symptoms too, such as depression, anxiety, developmental delay, learning disabilities. All of these are part of the comorbidities, and all of them can significantly impact quality of life. You want to review your seizure safety and seizure action plan. That's part of the rescue medications. And often we'll discuss risk of sudden unexpected death in epilepsy, or SUDEP. Next. What about those who have gone on to see an epilepsy subspecialist? What do you do then? Number one, if you go to see an epilepsy subspecialist, it is strongly encouraged that you meet back with your epileptologist or your neurologist soon after that consultation, so that you can review any of the new information that was gained, as well as the recommendations. You will sit down and discuss how this affects your current treatment plans and what you would like to do next. Sometimes there might be suggestions for additional testing, and so you'll review whether or not you want to proceed with it and if it's even possible. And all that will be done in addition to the usual appointment discussions. Next slide. So how do we get to a neurologist? Most will be referred by a primary care provider, but for the vast majority of people, this is not necessary. We're no longer really in the age of the HMO or gatekeeper. If there is concern that there's been a seizure, you can usually contact the appointment office. You can pull it up on the internet. You can contact the appointment office of any of, variety of neurology groups. In Minnesota, we are very fortunate that there are a lot of different places where you can receive neurology care. So I don't want you to think that you can't see a neurologist because you haven't gotten that referral from your primary care provider. It's often not needed. When patients meet with a neurologist, if it's felt that they need continuing care, such as people who have been diagnosed with epilepsy, often they're seen somewhere between 1 and 4 times per year, but that really varies depending on the need. I have some patients that I need to see more often. I have some patients that I wind up seeing about every 15 months because they're doing really well. And these are definitely easier to access for adults. And that's just a matter of math. It's not that we don't want to see children. It's that there are many more adult neurologists than pediatric neurologists. For example, at Mayo Clinic, we train 2 eventual pediatric neurologists each year and 10 adult neurologists each year. So that's why it's just easier to access for adults. Next. Travel can be an issue, especially for people with epilepsy. And again, I don't want you to ever feel like you can't get to your provider and you can't get your epilepsy treated because of travel. Many decisions can be made through phone calls and portal messaging. That's the other thing. Even if you're only seeing your provider once a year or twice a year, you shouldn't wait for that appointment if you have concerns. Feel free to contact your provider ahead of time. In fact, I really prefer it when my families do, because if there's a concern that seizures aren't properly controlled, I can make those recommendations for treatment change, and then at their follow-up appointment, we can talk about whether or not they helped. So we're far ahead of the game if we do it that way. Or the neurologist might work with the primary care provider to provide local care. I used to do an outreach clinic in North Dakota, and that's what I did. I saw the child and then wrote out my recommendations, including medications, and then the primary care providers did all of the prescriptions. That worked pretty well. And now telehealth, more so than any time in the past, is an option. And again, if you don't have access to a computer that allows you to do telehealth, you don't have good internet connections, this can often be done from your primary care provider's office. So excellent options to minimize travel. And for those times when you really do have to see your provider face-to-face, many clinics have social workers that can help with those transportation needs. Next. So what can you do to prepare? If you have recurrent or your loved one has recurrent indeterminate spells or new seizure type, it's really helpful to just get a video recording. That picture is worth 1,000 words, videos are worth 10,000 words. I have made the diagnosis off of a home video, and this is nothing fancy. Just, most people have phones now that can video record. Even if you don't get it right at the beginning, getting it towards the end, all of it provides excellent information. So plan to bring that with you. If they are happening more than once or on a recurrent basis, mark them on the calendar so that you can track the frequency, you can track how long they go on, looking at possible triggers. Bring all of your medications with you, and know your medical and family history as much as possible. Next. So now we move on to the level 3 and 4 epilepsy center. And I just combined those two, but basically these are the specialized centers. So these are doctors who are trained in neurology, or in my case, child neurology, meaning that we have gone to medical school, we've done residencies, either in neurology or in both pediatrics and neurology. And then we've done additional training in epilepsy and EEG. So yes, we've gone to school for a long time. Many of these centers will have an entire team dedicated to the treatment of epilepsy. And so we have neurosurgeons, we have neuropsychologists, social workers, nursing supports, EEG technologists, and neuroradiologists. So once you get to a level 3 or 4, that's why we call it a comprehensive epilepsy center, because it's not just a neurologist, it's an entire team of providers. Next. So what is available there? That's where we will do overnight prolonged video EEG monitoring. We have radiology services to do the MRI, and often we have radiologists with specialty training for reading brain MRIs, or sometimes we even have ones that are specifically trained to look for the changes that are often associated with seizures. We have lab services. We can do our comprehensive neuropsychological evaluation. What is that? That's essentially a fancy term for IQ testing. At surgical centers, it's where we can do surgical treatment for epilepsy, and we can also do rehabilitation after surgeries. Next. So who can be treated here? Well, of course, anyone. You know, this is an epilepsy subspecialty center. But we need to recognize that this is a limited resource. So we need to focus on who should be treated here. Again, this is both an underutilized and overutilized resource. So anyone who is still having seizures after trial of 2 to 3 medications, and they have not previously been evaluated by a comprehensive epilepsy center, should be evaluated at least once. These are the patients that will most benefit from a comprehensive epilepsy center evaluation. If someone has epilepsy with other neurologic symptoms of unknown cause, so, you know, weakness on one side, profound developmental delay, we really want to see those patients as well. If epilepsy is getting worse, that's an important red flag that suggests you need to have a comprehensive epilepsy center evaluation. What do I mean by epilepsy getting worse? I mean new seizure types arising, seizures becoming more frequent, seizures becoming more prolonged, people who are not coming back to baseline in between seizures. Those people need to have a comprehensive evaluation. And sometimes, especially in children, the only way to get really good coordinated care with multiple subspecialties is to work with a comprehensive epilepsy center. Next. So what can you do to prepare? A lot of it is the same as seeing any other neurologist. So try to video record seizures, track frequency and possible triggers for seizures, bring medications with you, know your medical and family history, but then also know previous treatments. So any of the medications you previously tried, it's really helpful if we know which ones you've previously tried and why they were stopped. If you really want to be fancy, if you know how high a dose you got up to, that's also helpful. Next. So what to expect? Overall, this is, again, going to be a consultation. For most patients, this is not going to be long-term care because, again, this is a finite resource. And so in order to get all the patients in for their consultation, we need to work with local neurologists. The evaluation may last one day, or sometimes it takes months before we have all the information in. Next. When you come in for your appointment, expect it to be a longer appointment, usually somewhere between 60 and 90 minutes. So if you're coming in with children, please bring activities for them to do. You know, if you're coming in with children or a dependent parent or dependent adult child, it is expected that they will be at the appointment. They may not necessarily need to be in the appointment the entire time. So if you want to bring another family member with you who can bring that person out to the lobby when they start to get restless, that's okay too. That's very helpful. But again, expect these to be longer appointments. appointments. And a lot of it is talking. It's going to be in-depth history, review of the evaluation done so far. And, most of us are not looking to just repeat evaluations for the sake of repeating evaluations. We're looking to complement what has been done so far. And we also want to do a careful review of the treatments that have previously been tried. Then we'll discuss the additional evaluation, and usually it's done to look for underlying cause, such as more imaging, MRI, more advanced, and even within MRI, there's standard MRI, and then there's epilepsy protocol MRIs. So even if you've had an MRI before, we may possibly be repeating those. Might do labs, blood, urine, sometimes even spinal fluid, and typically there will be an EEG. Next. What else to expect? Depending on other issues, there may be consultations with other providers, such as medical genetics or a dietitian. You'll have a discussion about long-term expectations. Is seizure freedom a possibility? Again, most people come to a comprehensive center expecting seizure freedom, but that's not a possibility for every patient. And if it's not, then we need to talk about what will improve quality of life. We want to review lifestyle, looking for possible pseudo-resistance. So patients who are still having seizures because they frequently miss medications, or overindulging in alcohol. So we're going to review that. And then we'll again review seizure safety and rescue plans. Next. So why? The reason for someone visiting a comprehensive epilepsy center after failing to respond to 2 to 3 medications is because that is a big sign that there is something about that epilepsy that just doesn't respond to medications. So let me say that again. If seizures have not responded to 2 to 3 appropriately chosen medications, it's not that your provider just simply hasn't found the right medicine. It means there is something about that epilepsy that makes it refractory to medications. And so when that happens, just continuing to go down the medication list is unlikely to provide seizure freedom, or even reduction in seizures. In fact, there are really nice studies in adults that show once you have gone through 3 medications or even 2 medications, the likelihood of responding to other medication trials is only about 5%. So we need to start thinking outside that medication box. We have to look for options other than medications. And those include surgery, neuromodulation, diets, cause-specific treatments, or sometimes other medication options. Next. So let's start with surgery. Who is going to have a surgery evaluation? Again, someone who has seizures that are likely coming from one region, so not patients with generalized epilepsy or whole brain epilepsy, but seizures coming from one region that have not responded to 2 medications. Why? It's because your best chance of seizure freedom or reduction in seizures is to pursue surgery. And when do we want to do it? We want to do it as early as possible. So this is not meant to be a treatment of last resort. If you have children, do not wait until they are adults. The long-term outcomes are much better the earlier seizure surgery is done. Next. So overall, about 20 to 40% of patients will not respond properly to medication. Again, after failing trials of 2 medications, on the adult side, less than 5%, and on the kids side, about 10% will have the ability to reach seizure freedom with additional medication trials. Add to that, and this is part of the reason to not delay this evaluation, the chance of dying from epilepsy is about 0.5 to 1% per year. So if you keep adding that up, you increase risk of seizure-related death. Next. So overall, it is felt that surgical treatment for epilepsy is arguably the most underutilized of all accepted therapeutic interventions in the entire field of medicine. So if you have focal seizures, and seizures coming from one area that have not responded to 2 or 3 medications, please go to an epilepsy center to see if you're a surgical candidate. Next. But you need to keep in mind that this is not meant to be an alternative to medication. People who have epilepsy surgery often are still on medications. So if you have seizures that are coming from one area, but you're seizure-free on a medication, the best place for your brain is in your head. Also, surgery success depends on being able to find the area where seizures are starting and remove the entire thing. But we're never going to do surgery if we know that it's going to, say, give you weakness on one side, or I would say never, but very, very unlikely. So if we know where seizures are coming from, we're able to map it out beautifully, but it's coming from the area that's controlling motor or speech, then you're not going to be a good surgical candidate. Next. And there are a number of different surgical options. We're not going to review this in detail, but this is just to let you know that, again, there are a lot of different surgical options that are available. Next. Overall, the outcome depends on if you have a lesion on the MRI, because then it obviously makes it a little bit easier for us to find where seizures are coming from, and if seizures are coming from the temporal regions versus outside. But again, it's not 100% that are seizure-free. In fact, it ranges anywhere between 11 and 72%, but it's still higher than the 5% that you might get just from medications. Next. And we can just keep going. Next. Next, there's also an option to ablate. And this is a newer technology that's pretty exciting. So this is kind of like non-invasive surgery, where we use a fine laser probe and use MRI, and we basically destroy the area that is causing seizures without injuring the surrounding area. Obviously, this has a much lower risk of complications compared to an open surgery. Patients are, kind of in and out. It's pretty exciting. Next. And so here we can see an example of, this is an area of the brain called the hippocampus. And so we're targeting it. In the middle, we can see an orange. We're using a heat map to estimate the area of damage. And then post-procedure on the right, you can see what was removed. So this is very exciting when you have an area, a small area where you know exactly where seizures are coming from. Next. Sometimes people who have very difficult to control whole brain seizures, called drop attacks, these are also called atonic or tonic seizures, may benefit from disrupting the connections between the two hemispheres. This is called a corpus callosotomy. And this can also be done either open or through the laser that I was just telling you about. Sometimes it's completely done, sometimes it's just the back part, sometimes it's just the front part, but this can be very helpful for drop attacks. Next. And so you can see long-term, we're starting off with 190 drop attacks per month, and it can drop down to less than 20. So not necessarily seizure-free, but a dramatic decrease in seizure frequency. Next. The other outcomes to think about is many patients report improved quality of life after surgery. And there may be some verbal memory deficit, but even with that, most patients have improved quality of life. Next. IQ might actually improve if people become seizure-free. You get reduced mortality from epilepsy complications. If you're able to be seizure-free, then you can drive and you're much more likely to be able to live independently. Next. So what to expect from a surgical evaluation. Imaging is going to be very, very important. EEG, prolonged EEG to record seizures. And then all of this information will be presented at a meeting with other doctors. You never want one person deciding whether or not you should have brain surgery. And then after that, the physician that you see will contact you. You'll either have an appointment or a phone call, and all of those surgical discussions will be, or surgical possibilities will be discussed with you. Next. So what to understand, not everybody is a candidate, and going down this path is only to see if it's a potential option. It does not guarantee that you are a surgical candidate, nor does it guarantee success of surgery. And it often leads to other testing. Next. So if surgery isn't an option, there are neuromodulation devices that stimulate the brain. Now, these are meant to reduce seizure frequency and severity, but they are not expected to lead to seizure freedom. So obviously, resection is your best chance, but if you're not a resection candidate, then we change our focus to reducing seizure frequency, reducing seizure severity. These are used with medication, and there are a lot of different options available. Next. I group it into the vagal nerve stimulator, responsive neurostimulation, deep brain stimulation, and cortical stimulation. Next. So if we can't find the seizure onset zone, we can't localize where seizures are coming from, or if we can localize it, but we can't remove it, then vagal nerve stimulation has been FDA approved for decades and is a very reasonable option. Next. Overall, it reduces seizures by about 50% in about half of patients, in both adult and kids. We have some, they've changed the model, and so now there's a benefit in up to 60%. So not everybody benefits from it. And again, we're looking at seizure reduction, not seizure freedom. Next. Deep brain stimulation, same thing. If we can't find where seizures are coming from, or if we can't safely remove the seizure onset zone. This is FDA approved in adults, but is used off-label in some children. Next. Overall, it's about a 2/3 reduction in seizures after a couple of years. Neuromodulation doesn't work right away. It takes several years. It's kind of like retraining the brain. So it takes several years to get maximum benefit. So it's about a 2/3 seizure reduction. Next. If we can find where seizures are coming from, but we can't safely remove it, that's when we bring in the RNS neurostimulator. This is also called NeuroPace. Next. And again, it's about, half to 2/3 seizure reduction. Next. If we compare them overall, again, VNS is the least invasive, but also is least likely to reduce seizures. But often that's where we go first because that has the best FDA approval. Next. And then last but not least, we have the subthreshold cortical stimulation. This again is if we can find where seizures are coming from, but we can't resect it. This is not yet FDA approved. Next. Again, we don't have good numbers for it. It's a little bit different than the responsive neurostimulator. The RNS detects seizures and then gives a little bit of a electrical impulse to stop the seizure, whereas the subthreshold cortical stimulator is giving an impulse all the time. Next. So take-home points, if you have focal epilepsy that hasn't responded to 2 or more medications, think about surgery. Go to a comprehensive epilepsy center to check out your options. Next. Okay, what about cause-specific treatments? Part of what we do at a comprehensive center is to look for an underlying cause. This is part of the blood, urine, spinal fluid labs. We might do genetic testing. Next. And that is because some epilepsies are due to an underlying metabolic cause that requires specific supplements or diets. Some might be due to autoimmune or autoinflammatory disease, and so we need immunomodulatory therapy. Again, this is typically used in addition to medications. And now we know that some genetic epilepsies have preferred treatments as well. Next. So what are some of those treatments? We might use diet therapy. In children is typically going to be ketogenic diet. In teens or adults, it's often going to be modified Atkins diet. And this is a very high fat, low carbohydrate, very strict diet that's designed to essentially mimic the fasting state and cause the body to produce ketones. Next. So who can be on the diet? Pretty much anyone. So let's focus on who can't be on the diet. If you can't properly metabolize fat, you shouldn't be on a diet that is mostly fat. And again, it is very strict. So if you cannot comply 100%, then you shouldn't be on the diet. Next. So who can be on the diet? Pretty much everybody else. Adults can be on the diet too. They're just not very good at being compliant. But oral feeders, G-tube feeders, pretty much any type of seizures, any type of cognitive abilities, they can all be on the diet. Next. So what do I mean by high fat? So for the ketogenic diet, the dose of the diet is the ratio of grams of fat to grams of carbohydrate plus protein combined. And so it is very, very low carbohydrate. Notice about 3% of the calories are coming from carbohydrates, 79% coming from fat. And again, that can vary depending on the ratio. People are always given sufficient protein for growth. We want to focus and make sure that you're healthy. But again, most of the rest of the calories are coming from fat. Next. Everything is weighed out on a gram scale. And so your typical meal will have the protein. The carbohydrate is not used for the fun stuff. It's used for vegetables or fruit. And then you might see, two sources of fat. Butter and heavy whipping cream are pretty common at all of the meals. And in fact, people drink, especially the kids, will drink heavy whipping cream instead of milk. Next. So how does it work? We don't know. But we do know that you need to have those well-controlled ratio for each meal, each snack. 100% of the meal and snack needs to be eaten, preferably within 30 minutes, and they have to be compliant 100% of the time. I will always remember my first keto kid. She did extremely well. The last seizure she had was when she got into her friend's Lip Smackers chapstick. And just that amount of carbohydrate took her out of ketosis and caused her to seize. So everything that goes in or on the child is dictated by a dietitian. It's very, very strict, but also very effective. Next. So yes, they need to eat all their meals within 30 minutes, preferably starting with the fats, then the proteins or carbohydrates, or as one of my little keto kids explained, she starts with the fats for her brain, she starts with the proteins for her muscles, and then she eats the carbohydrates for her belly. So that's the way we stick with it. Next. How effective is it? You can get seizure freedom in as many as 55% in seizure reduction and up to 85%. Now let's go back. Think about it. I just said that if you've tried 2 or more medications, your likelihood of seizure freedom was 5 to 10%. So yeah, it's strict, but this is looking pretty good. Next. Yes, seriously. So it is very effective, and you're not adding on more side effects from anti-seizure medications. Next. So how long do we do it? I ask people to give a trial of 3 to 6 months. If it hasn't worked by 3 to 6 months, then it's unlikely to work, and then we can stop it. But if it has worked, then we treat for 2 years and then wean off. And here's the really exciting part. If people are seizure-free during those 2 years, they often remain seizure-free after coming off the diet. Unlike the medications that just suppress seizures, the ketogenic diet is actually an anti-epileptic treatment. It causes changes at the brain cell membrane. Next. So what are the alternatives? We have the modified Atkins diet, and here you can just see I'm comparing the fat, protein, and carbohydrate contents. So the modified Atkins diet is has about the same amount of carbohydrates, but is not calorie restricted, allows a little bit more protein, is easier to comply with. The MCT oil is a medium chain triglyceride oil, and it's better at producing ketones. So you can get by with more carbohydrates, but you also can get a lot of GI distress from it. And then last but not least is the low glycemic index diet. That's kind of a South Beach diet. You're unlikely to produce ketones, but some people get benefit from it. And these are going to be used with medications. Next. So compare all that to the average American diet, which is about 55% carbohydrates. So 3% or 4% versus 55%. Next. Do they work? Absolutely. Again, they certainly provide better seizure control than the likelihood of additional medications. Unfortunately, compliance on the adult side is not so great, so we typically stick with the modified Atkins diet. Next. So take-home points, ketogenic diet, modified Atkins diet, they work when other medications don't. You're going to use it with medications and they require 100% compliance. Next. So what about other medication options? That's when you're going to sit down and discuss, are there some medications that worked better or were better tolerated before? What medications make things worse? Has there been an issue with compliance? Look at the timing. How often are medications given? Once a day, twice a day, 3 times a day? Sometimes in little kids, because of their absorption and metabolism, we have to go from twice a day to 3 times a day, and then we're able to get better seizure control. And look at the medication formulations. Is it the rapid release liquids? Are they extended release tablets? That's all going to make a difference too. That can help your seizure control. Next. So how does this help? Why are we circling back to medications after I just said that 2 or 3 medication trials means you're unlikely to be seizure-free with other medication trials? This is, again, where you can benefit from a comprehensive center. We know that some genetic causes of epilepsy have preferred medications, and so you can get much better seizure control if you're on those preferred medications. Also, some epilepsy syndromes or genetic causes of epilepsy also have medications that can make seizures worse. So that's going to be really important to explore as well. Some formulations are better tolerated than others. We have patients who were seizure-free on a medication, but they stopped it because they couldn't tolerate the side effects. We changed the formulation. They're able to tolerate the effective medication. We have better seizure control. Some medication combinations work better than others. And most importantly, the subspecialists, this is what we do all day, every day. We work with this collection of medications. So we're much more comfortable with medication dosing and using newer medications. Again, especially on the pediatric side, sometimes kids just need higher doses of medicines, and ultimately we give them what they need. And they're going to be more comfortable with those medication interactions as well. Next. So medication overall is the mainstay of epilepsy treatments. It is meant to suppress seizures, but it doesn't take away the cause of epilepsy. So again, these are anti-seizure medications. They are not anti-epileptics. And any other therapy that we discussed today are used in addition to medications. Next. How do they work? Overall, what we're trying to do is we're trying to balance out that excitability and inhibition of the brain. Next. So when we have a seizure brain, it is hyperexcitable, and so we get seizures. Next. With medications, we try to restore that balance, but if medication levels are too high, now we get inhibition and we get cognitive slowing, we get sedation. That's how we get side effects. Next. So do medications have side effects? Yes, they work on the brain. They're often metabolized by the liver and kidneys. So all medications are at risk for side effects. We are just not smart enough in epilepsy to have a medication that works on one specific part of the brain. It goes to the whole brain. Are they necessary? Yes. Are they the cause of all evil? No. Next. So again, we're trying to restore that balance, but keep in mind, next, if you have seizures, it is because there is an underlying abnormality in those brain circuits. They are a symptom of underlying brain disease, which means not only do you get seizures, but you also can have attention problems, you can have depression, you can have anxiety, you can have learning disabilities. So it's not just the seizures, it's not just the medications, it is the underlying brain. Next. Why is this important to understand? because up to 2/3 of people blame their anti-seizure medications for not being able to do what they want to do in life. And this is a very important thing to recognize, because if you don't understand that, you wind up cycling through medication after medication after medication, and ultimately it can decrease your seizure control. Next. So how do we minimize those side effects? We're going to try to pick the most effective, best tolerated medication and treat with the lowest effective dose. If we have people with multiple issues like migraines, then we'll try to use one medication to treat both the seizures and the migraines. But we need to understand that there is no perfect medication for epilepsy. Next. I tend to group my medications into the red light, yellow light, green light, especially for the cognitive side effects. And there certainly are some that are better tolerated than others. Next. What else do we try to do? We try to avoid just adding one medication on to the next. If something didn't work, like if there was no response at all and you're moving on to another medication, while you're moving on to that other medication, take away the first, or try to use medications that complement each other. We try to spread out the doses evenly, and if possible, try to give that higher dose at night. Next. So what do I mean by rational polypharmacy? There's multiple steps along the seizure pathway that medications work. And basically, we try to avoid using 2 or more medications that are in that same step. Next. What else can you do? Excellent compliance helps. It allows for a lot less variability of those blood levels, which means you have better tolerability and better seizure control. Next. So take-home points from medications. Changing how the medications are taken can improve efficacy and tolerability. Working with a specialist is still helpful and can maximize that medication efficacy. Next. So take-home points overall from your comprehensive center. If you are not seizure-free after trials of 2 to 3 appropriate medications, do seek a consultation with an epilepsy subspecialist. They can do additional evaluation to understand the cause of epilepsy and discuss treatment options. They can make recommendations for additional evaluation and treatment options, but this is usually done as a consultation and not transfer of care. Next. So how do you get there? Again, you don't typically require a referral from a primary care provider. Some clinics will do a consultation via telemedicine or even an e-consult, which can be done through the help of your neurologist or primary care provider. If you do need to travel, again, often the social workers can help with transportation and housing needs. And a lot of the larger centers also have outreach clinics that might come closer to your home. Next. For additional appointments, usually this is going to be limited to the initial consultation and then a follow-up visit, and then you will transfer care back to your home neurologist. If we're trying to minimize travel, and you do require additional appointments, again, a lot can be done through phone calls and portal messaging. We work with the local neurologist and primary care providers, and also we have telehealth. Next. So what to expect for follow-up? Again, it's expected that you will return to your local neurologist. Certainly you can come back if another plan is needed, but usually part of that follow-up appointment, to kind of round out your evaluation with that subspecialist is to provide a list of treatment options for you to take back to your neurologist. Some people may operate through kind of a hybrid, and I have several families that do that. They see me about every 2 years just to discuss new treatment options, but then the prescriptions, the day-to-day care is provided by their home neurologist. And then rarely that comprehensive epilepsy center does become the medical home. This is more so on pediatrics, just because they need to have that comprehensive multidisciplinary care. But even those kids still need to have a primary care provider, and often they still have a local neurologist, because if they were to have a medical emergency, they need to have someone locally who knows them. If they go to the emergency department, we want them to have a local provider. Next. So for our final take-home points, if you don't know if you have seizures, it's okay to start with a primary care provider. If you require urgent or emergent care, please go to the emergency department and they will focus on stabilizing your seizures and making it safe for you to then make an outpatient appointment with your neurologist. Most epilepsy care can be provided by level 2 adult or pediatric neurologists. Next. If seizures have been refractory to 2 or 3 medications, then you should have a comprehensive subspecialty evaluation at a level 3 or 4 center where you will discuss treatments beyond medications, including surgery, neuromodulation, diet, cause-specific therapies, and then also make medication recommendations. Next. If you see an epilepsy subspecialist, plan on this being a consultation who will then work with your home neurologist. That consultation may be just one day or might take weeks or months until we get all of the results back. Next. You don't need a referral to see most neurologists or epilepsy subspecialists. You can work with your primary care provider, but I don't want your care limited by the need for a referral. I also don't want your care limited by transportation or housing needs. There are ways to work around this through telemedicine, again, through e-consults, working with the services that are available, and certainly for follow-up, telemedicine, phone, patient messaging can definitely be used. Transportation should not prevent you from getting the care you need. Next. And with that, I again want to thank you for allowing me to participate in the webinar tonight and ask if there are any questions.
Yes, thank you, Dr. Nichols, for this really interesting information. Let's take a look and see what questions we have. We have one here. Any recommendations for seizure detection devices? I've been studying the Embrace 2 and an Apple Watch with the Seize Alarm app.
So the best place to look at seizure detection devices is the Danny Did Foundation, DANNYDID.org. Danny was a little boy who unfortunately died of SUDEP. His family created this foundation that's dedicated to seizure safety. And the reason why I like it is because it's commercial bias free. You go through to the devices page and they have information about all of the different seizure detection devices. I don't have strong recommendations, one or the other. The Embrace 2 is the only one that's FDA approved, but you have to remember that none of them are perfect. All of them are best at picking up, big convulsive seizures. But they're tested kind of in an artificial environment. Most of them are tested in the hospital because they have the EEG running at the same time. So nothing is perfect. Ultimately, go with what you think might work best. There are some advantages and disadvantages. The Apple or the Embrace can be worn all day, which is really nice. Whereas the other two that most people use, the MFit, which just picks up movement, it goes under the mattress pad, or SAMI, which is video-based, both of those work in the bed.
Great, thank you, Dr. Nichols. Have another one here. Do any epileptologists practice at general neurology clinics, or are they only found at comprehensive epilepsy centers?
Most people who are trained in epilepsy will work in academic medicine, but actually there are several, especially for epilepsy, who will do general neurology clinics as well, especially in private practice. When I think about our epilepsy trainees, several of them have gone on, they've used that epilepsy training to be able to provide rural care where they're doing their own EEGs. So you may be able to find someone who is specifically trained in epilepsy at a general neurology clinic. The difference is, so they have the training, but they won't have the same amount of support. So often even those people, if you have someone who, who does require that epilepsy subspecialty care, often will still refer to a bigger center.
Great, thank you. A couple more that came in here. Does the keto diet work good for focal seizures?
So the keto diet can be used for focal or generalized seizures. If you have focal seizures, the first question is whether or not you're a surgical candidate. If you're a surgical candidate, that's a relative contraindication to doing keto because surgery is more likely to be effective. But if you have focal seizures and you're not a surgical candidate, then keto is very reasonable.
Great. There's another one. If you don't catch a seizure on an EEG and the results are, quote, normal, what are other test options for determining the source of seizures in the brain?
That's where recording them on your, on your phone is going to be really helpful. Remember, EEGs only tell you what's happening right during that time. So an hour-long EEG or prolonged EEG. If an hour-long EEG is normal, often we'll go to prolonged EEG where, either it's going to be outpatient, an ambulatory EEG, or inpatient. If it's inpatient, then we'll reduce medications to try to record the event. And then otherwise, I can get a lot of information just from being able to see what's happening. Based on what people do during seizures, helps the neurologist localize where seizures are coming from or what type of seizures they're having. So that video is really important.
Great. Why is it so much harder to find treatment that works for epilepsy than for other diseases?
And the long story short is it's not. If we think about all chronic diseases in medicine, you're always going to have that, approximately 1/3 of patients who are not completely controlled with standard therapies. The difference is that it's much less tolerated for epilepsy. For example, I was telling Debbie the other day, my youngest child, the one over on the right, you can't tell there, but she's had 3 different eye surgeries. She does not have 3D vision. And I remember sitting down with her doctor after the 3rd eye surgery has failed. Her eyes happen to be going the same direction just during this picture. Half the time they're not. And I was sitting down with her eye doctor and he was explaining to me that, most of the time we don't need to go to surgery. And if we do, then the first one typically works. If we've gone to 2 or 3 different surgeries, then that tells us that this is someone who is not going to respond to surgery. And as he was explaining that to me, I was thinking, I've had this discussion before, except I was on the other end of it. And that really is the reality for most treatments. If 2 or 3 of the standard therapies don't work, then that tells you there is something about that disease process. The difference is that my child without 3D vision has her driver's license. Turns out you don't need it to have a driver's license, but you may keep that in mind if you're driving around in Rochester, that I do have a 16-year-old on the road who has no 3D vision. And so, so yes, she has very refractory eye disease, but it is not significantly impacting her quality of life. It's preventing her from the military career that she wanted, but not preventing her from being able to do her activities of daily living. On the other hand, if someone has incompletely controlled epilepsy where they have 2 seizures per year that occupies no more than 5 minutes per year, now they can't drive. Now it's affecting day-to-day activities of daily living. So all diseases have this, quote unquote, failure rate. The challenge is that epilepsy has such an impact on jobs, quality of life, and activity of daily living that it's just much less tolerated.
Right. Another question about the keto diet. Are there heart risks with that diet with all that fat?
Actually, no. So the Hopkins group has done a really nice job, and most of their experience is on the pediatric side, but they've done a really nice job following these patients long-term. And kids who are on full-blown ketogenic diet grow up to be adults that reach the expected height and size, they eat a wide variety of foods, and they do not have increased risk of heart disease. Some of that is because, you know, kids have slippery vessels. Some of it is we use it typically for a finite period, but we also try to use very healthy fats. So we use a lot of the unsaturated fatty acids, so a lot of olive oil, instead of, you know, straight up butter or mayonnaise. And that makes a big difference too. So, you know, these kids actually wind up eating a very, very healthy diet. And when they're coming off of keto, a lot of times families don't go back to the food that they were eating before then, because they've taken out a lot of the sugar, a lot of the processed foods, and these kids are eating very healthy.
Interesting. I think we have time for one or two more. At what point does it make sense to just accept that you have seizures? It says they've been seen at an epilepsy center. They couldn't help them. Does it make sense to go to a different epilepsy center, or at what point do you just give up and just live with the seizures?
Well, if you have been to an epilepsy subspecialty center, you know, some people might go to a second one, but, you know, hopefully as part of that epilepsy center evaluation, they've had that conversation with you, where they've explained the likelihood of eventually being seizure free. They've had the conversation about focusing on, you know, reducing high risk seizures, maximizing quality of life. And so if they haven't had that discussion with you, then you could consider going to another epilepsy center. But, you know, realistically, if you've gone to an epilepsy center and all of that discussion has gone on, then it's okay to go back and just work with your local neurologist. And yes, unfortunately, again, about 20% of the time, people will not be completely seizure free. Now, I have a number of patients that do that, but then they will check back in with me every 2 or 3 years just to see if new treatments are available. And that's pretty reasonable to do.
Great. And I think the last question we're going to have time for, and this is one I get quite a bit from clients at the Epilepsy Foundation. Where does medical marijuana fall into this treatment?
So yes, that's been around forever. And I should let you know that I am not opposed to medical marijuana at all. In fact, when Minnesota legalized it for a while, I think I was one of the top referrers. So I have a lot of experience with both the artisanal form, the state form, and the FDA approved form. So let's first define what these are. There is an FDA approved formulation of cannabidiol called Epidiolex. That's the name brand. That is the only FDA approved formulation. It is FDA approved for only a few specific syndromes: Dravet syndrome, Lennox-Gastaut syndrome, and then seizures due to tuberous sclerosis complex. We were part of those trials for the Dravet and the Lennox-Gastaut. And overall, and again, I'm talking about the FDA formulation of purified cannabidiol. The best I can tell you is that it is a medication, no more, no less. It has a lot of side effects. It has a lot of medication interactions, but it works for some people when other medicines don't, and it doesn't work for other patients, and then we take them off. You know, I love having more medication options, but that's it. That's as good as it gets. It's a medication. The stuff that you get from Minnesota, and Minnesota really did a very nice job having these two labs that provide a very consistent product. I think as far as the state-run programs, Minnesota did a great job, and they did it before most other states. So at least you're getting a reliable source that is going to be either purified cannabidiol or a combination of cannabidiol and THC, or straight up THC. Straight up THC isn't typically used for epilepsy. The dosing that you get of the cannabidiol is about 1/10 of the Epidiolex. Most of the time, it's like a 19-to-1 ratio of the cannabidiol and THC. That's what was initially used in Colorado, the Charlotte's Web. That's the ratio. I think that's how they come up with that. They can't push the dose up much higher because of that THC. It would cause a lot of cognitive side effects. I have a number of families who went on it when it first came out. Most of them have come off because it didn't make anybody seizure free. It has side effects, it has medication interactions, and they were paying out of pocket, and it was really expensive. So even if there was some reduction in seizures, the cost didn't outweigh, or the benefits didn't outweigh the cost. And then the final group is the artisanal group, the CBD that you can get anywhere from your veterinarian to your dry cleaner. So because CBD has so many medication interactions, when we're doing trials for other drugs, we have to screen the urine for CBD. And what we learned from that is if you are getting the over-the-counter stuff, you may just be paying for really expensive gummy bears. Not even everybody had any CBD in their urine. There's a lot of variability in what you get, and it's just not well studied. So that's the rundown. At best, using the FDA-approved stuff, it's another medication. Do I use it? Absolutely. I have a number of patients that use it. We have to monitor them very carefully. Am I opposed to it? Absolutely not. What I am opposed to is people who go into it thinking that it's a cure-all panacea, and unfortunately it's not.
Great. Well, thank you, Dr. Nichols, for all those thoughtful answers to the questions. I want to thank you again for being here with us tonight. Before we close out our webinar, I would like to remind everyone that the Epilepsy Foundation of Minnesota leads the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. I also want to put in a plug for our information services program. We are here to serve people with epilepsy, their families, caregivers, really anyone who needs information on various aspects of epilepsy. We provide free one-on-one support and customized tools and resources around a variety of epilepsy-related topics, and we invite you to reach out to us with any questions. I want to thank our sponsors for supporting our webinar today, and you can learn more about them on our website at efmn.org. I do want to say thank you again to Dr. Catherine Nichols, and thank you to all of you who have attended, and just have a great evening.
Thank you.